Tell us a little bit about what you think the success of WAPHA and PHNs more broadly has been in your tenure.
The Commonwealth fund PHNs, and they fund them as effectively a sort of meso planning and commissioning organisations. There isn't another entity that does what PHNs do. Now, to be fair, over that decade, you can imagine the core functions have really matured in that time. So 10 years ago, when we were awarded the contract for the 3 PHNs in WA, we were very unique. And at the time, the interim board, or the board that I had, really wanted us to not do more of the same, so to speak, that had been going on in the decades previously, but look to a model that we thought made sense for WA. So we applied for the then were, still are, 3 PHNs in WA, and we did that for a very good reason. And we also said in the tender, we actually only want 3, and we want 3 for good reasons, even though we've given you a compliant tender. And the reasons were, WA can be described as a one city state. There's a lot of movement from country locations, particularly in healthcare, to the city and back, and a lot of outreach, for want of a better term, to the country from the city. All the tertiary hospitals are in Perth. People fly either commercial airlines or indeed RFDS. But we had a view that to scale, having a model that would be cost effective, because we could decrease the sort of overhead costs by having a Perth-based centre but reach out into country WA. Anyway, we were awarded that tender, and when we started, I'm going to say lovingly, we probably had 3 people and a couple of boxes and went, oh. Anyway, over that time, of course, we've grown, but so has the scope of PHNs. We still have those core planning functions, albeit we've continued to refine that. I think the most important piece of maturity for WAPHA, for WA Primary Health Alliance, is that we've really come to crisply describe who it is we're attempting to serve and the outcomes we're trying to achieve. So we have a very strong health equity and access focus, which means we really target the resources we do have to those locations or vulnerable populations that otherwise may not receive health care. There was a hard lesson we learned, well, not a hard lesson, we just learned it straight up during COVID, that people in disadvantaged communities did not access vaccines early in that process anywhere near other settings in WA, because they didn't have the health literacy, they didn't necessarily follow the media that said you need to do this, whatever it was. It was so stark that it reinforced actually our obligation is to really strengthen the work we do, reaching those communities, but also supporting those practices that service those populations, because that's the other part of the jigsaw. Bulk billing had started to decrease, so people who may have used a bulk billing practice because they couldn't afford a gap, those bulk billing practices changed, to mixed billing, so people maybe didn't go as often, and therefore their health needs worsened, and then they end up going to hospital. So, and what we also know, and it's very clear, people who don't have the equivalent access to health care that's affordable for them die a bit younger, have comorbid chronic diseases more often. There's a whole range of things that collide, which from an ethical sort of focus, we need to do as much as we can. Can't drag people screaming to a service, but we need to do as much as we can to make it accessible. So the data's very clear about those vulnerable populations, apart from people who could be working poor but are on concessions and so forth. People who are newly arrived immigrants to Australia, or indeed non-English speaking background, particularly that first generation, second generation are more adept. LGBTIQ+, both from a physical health but also a mental health perspective, are higher risk. And then Aboriginal people, which we all know well.
It's also an organisation that's got a very strong internal culture, and it takes what you say seriously around things like diversity, inclusivity, equity within the organisation.
I've always had the view that you get the culture right, the rest will follow. I know people have had that old adage, strategy and the iceberg and all that sort of thing, but for me, PHNs have this inherent challenge, which is we have to remain agile, we have to be very flexible to whatever it is the Commonwealth want, and we expect a lot of our staff, and therefore the culture becomes important. Because, if I'm a staff member and I need to trust this organisation's got my best at heart, I need to therefore be adaptable along the lines, because it's a really challenging environment. And similarly, all PHNs, we're not alone, they're criticised a lot, largely by stakeholders who have a vested interest in something. We have no vested interest, we're just trying to do the right thing. And I think our staff feel some of that. So it's important our internal culture is robust to support them. We've got a really diverse workforce, which is wonderful. We work hard at being a safe, inclusive, values-driven culture.
Where to from here? For yourself, but also for some of the wicked problems in the health system.
Oh, there are some wicked problems. That is true. But for the wicked problem, the development through the National Health Reform Agreement, which has this tripartite agreement with the state and the Commonwealth, I think is the building block. A genuine partnership to start to build that interface between primary care and acute care, and wherever possible, us to help shape, influence, to get the outcomes for primary care as well as the acute system. But so much happens where a GP may not know a person's even been to hospital, let alone discharged. But there's a whole suite of things, and the state, to be fair, is developing things now that are really going to be great enablers for general practice, which we think is a good beginning. So hopefully, if we had our wish, you'd never develop a health system in the way it looks today. If it was a greenfield site, leave that out. But surely we can start then making moves to linking and integrating care. So ultimately for us, it's having that integration pathway piece, very explicit rather than not. And we do quite a bit of work trying to join that up with the state to make it easier, but better outcomes for everyone. Ultimately, I hope I've created a legacy that can be built on. Doesn't mean it won't be different. We've really been at the forefront in terms of the digital environment and data, and that will continue, I'm convinced. But there are other things, such as this North Star, for want of better jargon, around equity of access, that I think is important, as well as the culture. So I just hope, all I hope for, it's like handing over a baby really, that it's built on and strengthened and it keeps growing, even though it'll probably be a bit different.